of metabolism to discuss it. And what we will do is we'll talk about the treatment and management of IEM through case studies. Uh, Interestingly, the the conference for inborn errors of metabolism is being held in Jaipur, and we've got the experts on the eve of that conference. To introduce Dr. Seema Kapoor, who's going to be chairperson and moderator of this lecture. Professor Kapoor is at Maulana Azad Medical College. She is one of the topmost experts in the country on IEM and genetic disorders, and has a lot of publications to her credit. She's running a very robust program on newborn screening and other aspects. Uh, I'll request Dr. Seema Kapoor to take over the proceedings and introduce the speaker. She knows the speaker very well. The speaker is Dr. Sunita Bijani, and don't let her get away with just drinking coffee on her own. Okay? So, Dr. Seema Kapoor, please go ahead.
So, good evening, everybody. And it's indeed a great privilege that today we are talking about IEMs and newborn screening across the country. And it cannot be a more opportune moment than this. Uh, it is my great pleasure to introduce Dr. Sunita, who I think is one of the leading metabolic physicians, not only trained very well in metabolics, but has extensive work on metabolic disorders. So, as a team, I think in Gangaram, she really looks after a large number of patients with metabolic disorders, especially IEMs, and know that not that our focus is less on the omics part of it, but the metabolomic part is very, very strong. So, Sunita, will you please start this great session on this great evening? And I thank IAP and Dr. Anupam to give us chance to do this.
Thank you, ma'am. Thank you, Anupam sir. Thank you, Dr. Anil sir, for the opportunity. So without much delay, I think I can start. Can I share my slide, please? Yeah. So I hope my slides are visible now.
Yes, ma'am. Yes, they are.
Okay. So the topic for the discussion today is treatment of small molecule types of inborn errors of metabolism. So as we know that we are into the therapeutic era of these metabolic disorders, we started very small with very minuscule type of treatments like diet measure modifications, etc. But now we are going very high, and in fact we are going to infinity and beyond. And that's why I put this buzz light here, just to wake us all up for this talk. So I will mainly be focusing on treatments of these inborn errors of metabolism. But before I get into the treatment part, we will just understand what these metabolic disorders are. So basically, they are the inborn errors of metabolism, means that they are inborn, which means they are inherited. They are defects in our genes, and genes basically code for enzymes for many proteins. So because of the defect in the gene, there is problem with the enzyme functioning, and then there are lots of chemical reactions in our body. So they all get disrupted. So in this very simplistic diagram, we can see that a substance, one which has come into our body, needs to pass through a lot of membranes, go through certain intermediary steps to give rise to a final common product. And if there is a defect in any of these steps, there we have the metabolic error, and that's how the disorder comes around. So these inborn errors of metabolism can be broadly classified. Before classification, our basic understanding over the years had been that these inborn errors can be characterized as such based on a biochemical method of detection. But now in this NGS era, this definition does not hold true anymore, because now we define inborn errors as any disorder which has a biochemical basis which is intrinsic to the pathophysiology of the disease, whether or not it has a biochemical method of detection. Because there are so many inborn errors where you cannot actually detect on biochemistry. You need genomic testing, like congenital disorders of glycosylation, mitochondrial disorders, and so on. So our definition is broadening, and a number of disorders are also increasing. So, but from a clinical perspective, basically we characterize them into three groups. The first is the intoxication type, where there is a small molecule which is there is acute accumulation of this molecule because of some block in the pathway, and which give rise to toxicity in the body. For example, the urea cycle disorders, where there is accumulation of ammonia which gives rise to the neurotoxicity, and so on. Then the second category is the energy deficiency type, which directly relates to the formation of energy, which could be mitochondrial or it could be cytoplasmic, like the glycolytic pathways. Then the third largest group of disorders is the complex molecule or the storage type. It's a old classification. Complex molecule can be storage type or and also synthetic and other trafficking type as well. So now we have evolved into this era, and now there is a new international classification of inherited metabolic disorders, where there are 130 classes and more than 1,800 disorders. But we still stick to our simplistic classification of small, complex molecule and energy deficits. So today we will be focusing on the small molecule disorders, which could either be due to accumulation types, like I said, the urea cycle, or even deficiency types. Now let's talk about the treatment. So now, as we know what happens in our body because of these IEMs, we can now start to think about treating these disorders. So as we know, biochemistry is metabolism is a biochemistry in the body, and defects are related to all these biochemical pathways. So intervention is possible. It could be at any of the steps, and it can give rise to a good improvement in the body. So, better understanding of the biochemistry is now paving the way for innovative new treatments. So, intervention at the level can be at various levels. So, at the level of raw ingredients, very simplistically, if we take one disorder like the phenylketonuria, it is a disorder of metabolism of one amino acid, which is phenylalanine. So, if we intervene right at the first step, if we just reduce the intake of phenylalanine in our body, that is the raw ingredient, we are able to help the body improve and not cause further toxicity. So that substrate reduction is brought about by diet. So dietary modification is the age-old technique of treatment for these small molecule disorders. So PKU is the classical one. We all know that there is newborn screening, which is more than 60 years old all over the world. Now, we in India are now trying to get to newborn screening with the madam's help as well. So, this is the first step of treatment where you intervene at the level of the substrate. Then there are many intermediate pathways. So you can supply a product in between, or you could remove the toxins which are coming around because of the block, such as hyperammonemia. You treat by giving ammonia scavengers. And in very acute situations, you do dialysis so as to get rid of that acute toxin. And there's another innovative method of treatment is to reduce the production of the toxin as well. So what you do is that you try, if there is something that can suppress the biochemical pathway, even before the step where the toxic metabolite is getting produced, then you can achieve your goal. So this is classical example of this treatment is tyrosinemia. So what happens in tyrosinemia, I think I have a case, I will allude to it later. Then, of course, supply of the final product. So there is a deficiency of a product which is giving rise to a disorder. A very good example is like the congenital adrenal hyperplasia, where there is a deficiency of the steroid hormones. All you have to do is supply these final steroid hormones, and the children will be fed fine. So, but we can do more than what I have just alluded. So basically, now in this new era of treatments, we are now looking into the pathophysiology as well as trying to replace or supply the missing products. So, such as the gene therapy and or the enzyme replacement therapy. Enzyme replacement therapy is not that new. It can be brought about by giving the actual enzyme, which is a regular process, should happen lifelong, or it could be a supply of any organ. So, for example, bone marrow transplantation, which will give you a ready access to the enzyme all throughout the life, or it could be a chaperone therapy, cofactor replacement, and so on. So now there are various methods of treating these small molecule type of inborn errors of metabolism. So the trajectory of the IAM discovery and treatment is such that while the discovery is more than a century old, the treatments have actually lagged behind. And it's only recently that we have pulled the gear and we are into the fast mode of finding treatments, all with this gene therapy at all. So now I'll start my cases. So this is a 2.5-year-old girl, resident of Kashmir, who started having seizures at the age of 6 months. And along with that, a global developmental delay was noted in her. So while her birth process was uneventful, she came to medical attention and was referred to us at around only 2.5 years of age. So when so this is an older picture, but when she came to us at 2.5 years, she had light colored hair. Her weight and length were lagging behind. She was having failure to thrive, and her developmental quotient was also lagging behind. So upon investigations, she was noted to have a very high phenylalanine level. While the normal levels are anywhere less than 100 or 120, her levels were 1400. So that's how we diagnosed her to have phenylketonuria. So now we know that there is good treatment for phenylketonuria using just the diet. So her mainstay of treatment is dietary modification, wherein two things are done. First is you restrict the natural protein intake. You do not allow the diet which has high protein, such as non-vegetarian, milk, dals, etc., and limit even the other foods to a certain extent, and then supplement the protein using a special diet which does not have the offending amino acid, in this case phenylalanine. So this is how a combination of this restriction of natural protein as well as supplying a specialized protein formula gives rise to good treatment outcomes. So there are now many, about more than 15 disorders which are now amenable, and they are receiving treatment through this kind of measure, that is dietary management. So these are the groups. Most of them are intoxication type. Now, like I said earlier, mere supply of the final end product is also sometimes a treatment for disorders, and a good example is the congenital adrenal hyperplasia. Another case, so this was a child who started having seizures at around 3 months of age. He was started on anti-epileptics and biotin at the same time. His MRI had shown features suggestive of hypoxic changes. The EEG was abnormal with irritative foci. Then the TMS, the metabolic screen using tandem mass spectrometry, and urine metabolic screen were actually normal. So the seizures improved, child went on to do well, but at 2.5 years of age, the child started having alopecia. And this was when the parents had actually stopped his biotin therapy unknowingly. They said, child is doing well. We don't know what is wrong with him. There are no more seizures. So they just stopped it. So when the alopecia occurred, they came back to us, and that is when we realized that the child actually had biotinidase deficiency. So the enzyme activity done at that time was very, very low, suggestive of biotinidase deficiency. We restarted the child on biotin, and which led to good appearance of hair again. And this is how the child is now, who has normal hair growth. His growth and development had actually been normal. So by default, he was doing well because he was on biotin treatment. So this is another good example of treatment, very simplistic treatment leading to excellent results. So, biotinidase is an autosomal recessive inborn error of metabolism, leading to shortage of biotin in the body because of the recycling defect. Treatment is for the diagnosis, all you need to do is do the biotinidase enzyme, which is easily available in many majority of the big labs, including Gangaram Hospital. So it's a serum biotinidase assay, and we look at the percent of activity. Less than 10% activity is what we see in profound deficiency, and partial deficiency is when the activity is between 10 to 30%. Treatment involves only a small tablet of biotin per day, anywhere between 5 to 20 milligrams per day. One small caveat is to avoid raw eggs because it has avidin, which hinders the absorption of biotin. So coming to case number 3, so this KP was a 10-month-old baby girl who presented with abnormal body movements and stiffness at around 6 months of age. She had global developmental delay and failure to thrive. So at 6 months, she was weighing only 6 kgs. Her head circumference had also it had decelerated. So on investigations, the MRI had shown abnormality with atrophy of the cerebral and cerebellar hemispheres. The TMS had shown phenylalanine elevated, with a plasma phenylalanine being very high at 3,000 micromoles per liter. So it was the whole exome which gave us the diagnosis of PTS deficiency, 6-pyruvate PTPS deficiency, which is basically a cofactor of PAH enzyme, the BH4 synthetic pathway defect. So it is another condition with hyperphenylalaninemia, but which is not PKU. So it is a non-PKU hyperphenylalaninemia where the treatment differs slightly. We do have to manage the high phenylalanine, but the cofactor which is involved or is involved in 2 or 3 more reactions. So we have to take care of those reactions as well. So here, the treatment involved giving Kuvan, which is tetrahydrobiopterin, the cofactor itself. So this cofactor given at doses of 2 to 5 milligram per kg per day was started, and along with the other hormones, the syndopa, the 5-hydroxytryptophan, and folinic acid, along with dietary restriction, and which led to excellent results. So this is a follow-up. Yeah. So this is the little girl at 18 months who's playing with her older brother. She has good developmental progress. She's thriving well. She has good biochemical stability. So this is a good example of biotin cofactor replacement. So then coming to IEMs presenting acutely. So whenever a patient presents in acute emergency, such as encephalopathy, they can have metabolic acidosis or seizures, or even hyperammonemia or any other organ dysfunction. We had to look into acute toxicity, and the immediate treatment would be to the removal of the toxin as early as possible. So strategies like the extracorporeal dialysis is important. So one good example is hyperammonemia due to urea cycle defect. So basically, it's the ammonia which is the toxic part. So it can be tackled in 2 ways. One is drug therapy. So there are drugs which are able to scavenge this ammonia into relatively non-toxic metabolites and getting rid of the body of these metabolites. So sodium benzoate is basically able to conjugate with glycine to form hippurate, and sodium phenyl acetate conjugates with glutamine, which has two nitrogen at molecules, and is excreted from the body as phenyl acetyl glutamine, and that's how the levels of ammonia reduce. But it also has a limit, and we in our country we do not have ready access to sodium phenyl acetate or phenyl butyrate, so that's how only sodium benzoate is available. So, in the urea cycle, if there is an acute toxicity, the best way to treat these individuals is using the extracorporeal detoxification methods, the best being hemodialysis, and if not available, then a poor alternative is peritoneal dialysis. So, continuous veno-venous hemodialysis and continuous peritoneal dialysis in acute management is now a well-known thing. This is a slightly old paper, but we also have experience of treating the children using hemodialysis to very good results. Again, the same. So coming to another case. So this was a 6-month-old boy who presented from Chhattisgarh with a progressive abdominal distension and a failure to thrive. He weighed only 5 kgs at 6 months with the birth weight of 3 kgs. So this picture is a little later, so please do not go by this picture. He also had anemia, pale stools, rickets, as you can see, and hepatosplenomegaly with an umbilical hernia. On testing, his liver functions was deranged, but what was most deranged was the serum alkaline phosphatase and the INRs, and a massive elevation of alpha fetoprotein, with abdominal ultrasound showing coarse liver ecotexture with irregularities, with hypoechoic nodules, with enlargement of the kidneys and echogenicity. So all these features led us to believe that this child has a metabolic disorder, and that too tyrosinemia. And so we did the pathognomonic metabolite for this condition, which is urinary succinyl acetone, which was way high, along with elevation of tyrosine. And this was substantiated by the genetic testing, which showed a pathogenic variant in FAH gene. So this was hereditary tyrosinemia type 1. So the child was started immediately on treatment, which is a combination of protein, dietary modification with protein restriction, and specialized tyrosine-free formula, along with the medical intervention, which is a drug called nitisinone. So how this nitisinone works is like this. So tyrosine is broken down or catabolized to form energy by way of fumarate and acetoacetate, which enter the Krebs cycle. So it's the last step of this degrading pathway, which requires the enzyme FAH, which is deficient in children with tyrosinemia type 1. So what happens is, because of this metabolic block, the immediate proximal metabolite, the fumaryl acetoacetate, takes another path and starts forming succinyl acetone, which is the neurotoxic metabolite. So innovative therapies have come up 3 decades ago, and by serendipity, I must say, that this is an insecticide which was known to inhibit this step of tyrosine degradation, which is quite helpful, because what it does is that it at least reduces the formation of succinyl acetone, which is the toxic metabolite. So by giving nitisinone, you are able to do away with this toxicity of succinyl acetone. And what we are left with is managing the high levels of the amino acid tyrosine itself. And that's why the role of protein restriction by combination of reduction in natural protein and supplementing specialized medical formula which does not have tyrosine or phenylalanine. So that's how this child was started on treatment, the diet as well as nitisinone. It is a good example of substrate reduction therapy. Now, addressing the main issue, this slide I have shown again. So there are other methods like in phenylketonuria. There is now an established therapy which is enzyme, but this is not a PAH enzyme. It is a it is an enzyme, the pegylated form, which is able to metabolize the excessive phenylalanine from the body so as to reduce its levels in the body. So this is the PAL enzyme, the phenylalanine ammonia lyase. So when you give this enzyme, this particular enzyme cannot be given like this. It has to be pegylated. So when you give it, what it does, it just scavenges the phenylalanine from the body and thus allowing its reduction in the levels to very good results. So people have now started giving enzyme-based therapy for PKU along and sometimes along with the cofactor BH4. This kind of therapies, another enzyme replacement therapy which is coming up is arginase deficiency, where there is an enzyme. It's interesting because the L-arginase enzyme was actually created not for this condition, but for treatment of cancers, where one has to deal with the excess uh, enzyme. So another enzyme replacement therapy on the cards is pegtibatinase, which is for classical homocystinuria. Just, I think, one more case. So this is a little girl, 16 months old girl from Kota, Rajasthan. She has global developmental delay and hypotonia with these patchy hypopigmented and hyperpigmented patches over the skin. So there was no significant family history, non-consanguineous couple, previous healthy child, presenting with hypotonia and subtle dysmorphism and these skin features. So there was really no clue as to what she has. So we had to resort to whole exome sequencing. So whole exome sequencing brought about a variant in the X-linked gene SLC35A2, which was actually a variant of uncertain significance. Now, we did some post-exome study on the computer with the deeper study of the variant, and the computer prediction did say that it may be pathogenic, but we could not substantiate this unless we had more evidence. So we did the X chromosomes inactivation, which was normal, but this particular transporter is used in the galactosylation pathway, and that's how we did the transferrin isoforms, which is sort of a biomarker for the group of disorders, which is called congenital disorders of glycosylation. So this test came out to be abnormal, and thus we could say that there is some functional evidence of this variant being pathogenic, and thus we could change the classification to likely pathogenic. So this is interesting because the role of this transporter in glycosylation is such. CDGs are genetic disorders caused by pathogenic variants in genes which are linked to protein or lipid glycosylation. This, by saying this, I mean the post-translational modifications. So whenever a protein is translated from the DNA, it is raw. It needs further modifications in order to come to its active form. So these are called the post-translational modification. And one of the main methods of this is glycosylation, which means adding some glucose or other carbohydrate moieties to a protein. So the glycosylation pathway is very complex. First, it involves the production of the glycosyl moieties, and the other is to transport it to where it is required. So here, just putting it simplistically, there is this enzyme, the transporter. What it does, it is required in, so this UGT protein transports the UDP galactose into the ER or Golgi in order to enable the generation of these glycans. All it has to do is take the galactose and put it inside the endoplasmic reticulum. So if this transporter is not working, the galactose is not able to get inside, and all the processes are getting stalled. So patients do present with epileptic encephalopathy, developmental disability, growth deficiency, and dysmorphism. So all of this was there in our child. And there was this great article which says the clinical and biochemical improvements with galactose supplementation. So a mere sugar, which is very easily available as a chemical product initially, is able to do some remarkable improvement. So galactose supplementation may partially overcome the Golgi UDP galactose deficiency and improves the galactosylation. So that's what was done. We started her on this galactose sugar, the D-galactose, starting from zero point 0.5 to 1.5 gram per kg per day. And we have seen remarkable improvement. So the girl who was not even able to lift her neck is now sitting. Actually, this is still old. Now she's walking and she's talking. She's about 3.5 years old now, and she's doing very well. So, last but not the least, is gene therapy the ultimate goal? So, because the defect lies with the gene, what if we are able to supply this gene? So, this is done by two methods, either in vivo or ex vivo. And there's just one example that I can give you of this 4-month old boy who had come from Iraq. This boy, born to consanguineous parents, had presented with large head since birth, seizures since 10 days of life, and severe developmental delay. He was very irritable. In fact, he was being treated as another metabolic disorder of glutaric acidemia, which he didn't have. So he was ultimately diagnosed to have, because of the MRI findings of bilateral hyper T2 and flare hyperintensities uh, with normal corpus callosum. This was, in fact, a patient who had Canavan's disease. So the MRS had shown significant elevation of N-acetyl aspartate. So around that time, the gene therapy trials were going on in the US, and this patient, on his own efforts, got in touch with the researchers, and they agreed for the treatment. And I'm just going to rush through this. So, and he's now doing very well. So basically, the type of defect drives the treatment. Uh, we are talking about gene therapy here. I wouldn't perhaps go into details, just to say that it's not very simple. One has to look into it very carefully, the type of genetic defect, the type of disorder, and how it would be possible to do the gene therapy. But sometimes we take in this fact into consideration, that however expensive it may be, it perhaps is just a one-time cure. So I would like to conclude by saying that IEMs are an exciting group of conditions waiting to be explored. Importance is increasing, considering the vast areas of advancements in early diagnosis and treatments, enabling improved survival. Treatable component rapidly is increasing, and there are more happy stories now. A high index of suspicion can lead to early treatment and improved outcomes in children. Optimal utilization of resources are necessary, including NGS, to patients' benefits. And then in the field of treatments, perhaps we are only just getting started. So in cases who are non-salvageable, of course, the role is to still test, because you would like to not only prevent future recurrence in the family, but there might be something in store for this particular child somewhere down the line, if not today. So always be hopeful. And if nothing but at least store the blood of any child in EDT or dried blood spot wherever a situation arises where it's an unsalvageable condition, and just for the sake of the family. So thank you very much.
I think, Sunita, it was an excellent presentation. Can we have a big round of applause for her first before we take up any questions?
Ma'am, I would love to interact through questions.
Okay. So so she's actually given you the wholesome view of A, B, C, and D of metabolics, where and what to supplement and how. So let's look at the questions which are going to come in. There are participants. Can we have a Q&A session? Or maybe they are too overwhelmed with your talk that probably they are thinking that so much is possible now in IEMs.
Yeah.
What is, I think, an important thing which I should add on is the National Rare Disease Policy. In case a disease is notified under the National Rare Disease Policy as an IEM and has a treatment which is of benefit, it can be given to the patient free of cost. So, adding treatment costs also will be a real important thing in the management of children with IEMs. I think, Sunita, you've done a really good job. If we have any questions, otherwise, I'm going to pose some questions to Sunita.
I'm sure you're most welcome.
Yeah. So, Sunita, you have told us that dietary therapy is really very important. And do you have any idea about what is the current status of dietary therapy in India? I mean,
Yes, ma'am.
about diets being manufactured, or are we still importing the diets?
Yes, ma'am. Yes, ma'am. Thank you so much for this question because this is very practical and very important question. So up until 2013 or 14, we did not have anything which was getting manufactured in our country. We had to resort to importation, and that also was extremely difficult because of the regulations. So, thankfully, we now have at least two manufacturing units in our country. One is Pristine Organics, and the other is SP Enterprises. And they are manufacturing these special diets for at least 15, 17 disorders. Uh, so far, they are doing all right. They have managed to treat. We are managing to treat so many children thanks to those diet companies, but of course, a long way to go.
Yeah.
And
And
yes, ma'am.
many more are trying to come into the
Yes,
armamentarium
ma'am.
to manufacture
Yes, ma'am. Even
specific.
the foreign companies are trying to get into India because their products are, of course, timed and tested, and they are much more robust.
Right.
But we are also doing well. Thank you.
So I think also that ICMR in collaboration with Ministry of Health is trying for indigenous manufacture for these foods for special medical purposes. I have a very important comment to make to you. As Dr. Sunita pointed out, that in phenylketonuria, you restrict the normal protein. That doesn't mean you completely abstain from the normal protein, but you supplement the protein. So these are foods which are made for special medical purposes and in no way interfere with the breastfeeding policy network of the country. So it's very important that these foods are life saving. That's important. Secondly, Sunita, you have said that about gene therapy, there is, um we have to fly out. Are you aware of any centers which are likely to come up in India for gene therapy?
Yes, ma'am. So a lot of things are happening in our country as well, but at the moment they are at the level of basic research. So at the level of animals, they are doing. At least we as one center are involved with one gene therapy along with IIT Kanpur for the Duchenne muscular dystrophy. I'm sure you also must be knowing others, and we heard some gene therapy, research getting happening for methylmalonic acidemia. So, of course, our country is ripe with all
Very important.
this.
So we patients may not need to fly off to
Yes,
any other countries in another 2, 3 years time, and we will have gene therapy very much available for many disorders in the country. And once that happens, not only the cost of treatment, but the feeling that these are non-salvageable. Maybe I can do nothing about them. That feeling will go. And gene therapy will actually not only cut, copy, and paste the gene, but believe me, will be a great surgery. It's the editing is going to change And there are so many ways of editing that are now coming up, and India is also coming up with these methods. So she's talked about gene therapy, she's talked about dietary restriction, she's talked about intermediate suppression. And there are the best thing in India is that we've risen in IT, but in the field of genomics also, there is a marked presence of Indians across the world who are really doing very well. So maybe in collaboration, one of the days, Sunita might come up with a patent on treatment of one of the metabolic errors. So I think the big key messages are that once you diagnose an IEM, many of them are now treatable. Even the complex disorders, ERTs are available. The small molecule IM diets are available. Cofactor therapies, they're very much. Chaperone therapies are available. Substrate and toxin removal. So I think the Dr. Anupam, very important message is people should not lose hope. And the continuous renal replacement therapy, which is very important in the newborn period, should be emphasized to salvage that period so that they can come to the stage that diets are available. Diets can help them. If they don't pass the acute metabolic crisis, I mean, we cannot offer them diets. And there are many examples at CRRT, very simple procedure done in the pediatric ICUs and in neonatal ICUs well can actually remove these toxins very effectively. I think basic three or four important messages for all the members here who are present and listening is that we do not lose hope. We continue to probe ahead. The example that she gave on adding galactose, a very, very low cost molecule to improve, and the videos were very impressive. You can imagine supplementing such low cost therapies. And the also another important message, nitisinone was being imported from India for a long time and was being supplying outside. But now nitisinone is being manufactured in the country by more than 2 to 3 pharmaceutical companies who are waiting to come into the armamentarium. So we have much reduced costs of therapy as well. So I think cost has come down, genomics have improved, proteomics and metabolomics has improved, and probably I think these are good challenging cases that Dr. Sunita has presented today.
Thank you, ma'am. Thank you.
Looks like there are no more questions. Do we have one something in the Q&A box? Okay, the question, Sunita, for you is when to suspect IEM in a child with seizures and developmental delay? So, I mean, the metabolics of seizures, right?
Yes. There is no particular pattern that an IEM will present with. So you really have to keep a high index of suspicion, especially if it is a little baby or an infant who has presented with an unexplained seizure, because you can have seizure, you, s- unsuspected febrile seizure in normal children, or for with any infection like meningitis. But if you don't have any other explanation, you must think of a metabolic cause, a genetic cause, and you must uh, do two things simultaneously: diagnose and start treatment, because there is not much time the child will give, for you to be able to salvage the child when they present acutely. So what we do in seizures, acute seizures, is we can give the therapeutic trial, what we generally do, of the vitamins, the B1, B6, B12 injections, and the biotin and folinic acid. So these are 4, 5 vitamins that can be given empirically in order to, in a suspected child who has continuous seizures, intractable seizures, and simultaneously also investigate to find the cause. So that's how it is. Thank you.
So, do I see any other questions in the Q&A session? No, I don't see any other questions.
Right, ma'am. Okay,
Right.
then. Shall we?
We've had a good session, and I must thank Indian Academy of Pediatrics, Dr. Anupam, for hosting this session. Right?
Thank you for sharing, ma'am. Thank you so much.
Thank you. Okay. Right. So I think can we close the session now?
I think we could. Okay, ma'am. I think we can go.
Okay, I think we
Yes,
can.
ma'am.
Gaurav, we'll close
Yes,
now.
ma'am.
Okay.
Yes, yes,
Thank
yes.
you. Thank you.
Thank you,
Thank you,
ma'am.
ma'am.
Thank you. Thank you, Gaurav. Good night.
Good night.